Yes, ma'am, we are live now, ma'am.
So, Team Oxy Reproductive Health Committee webinar on case scenarios and troubleshooting in PCOS by the Oxy Reproductive Health Committee. I would like to thank our President Madam and our Treasurer, Sampath Ma'am, Meenakshi Sundaram, for having given this opportunity. And we would go with the dialogue series with Dr. Puvitra Tanikachalam and Dr. Bharati. To start with, I invite all the faculty, the speakers, and the delegates. I can see a senior person, Savitri ma'am, Tara ma'am. Now, to start with, can you display the Oxy prayer, Sahiti? Oxy prayer. Thank you, God. In humility, we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Request yeah, Kutuvilakku, lighting of Kutuvilakku. Dr. Rajapriya, madam. She is the executive committee member of Oxy, Home Fertility Center and Srinivas Priya Hospital, Perambur. She is a patron, Indian Fertility Society, IFS quiz, and secretary, Women's Wing, Perambur, managing committee member, Oxy, sexual health committee member, Oxy, ICOG, Foxy, RM course head in Chennai, MRCOG part 3 examiner, and Dr. Aruna Ashok. Next slide. She is Fertility A4 Fertility Center and Hospital. She is a EC member of Tapisar, Oxy, member of ISAR, gold medal in MBBS, JIPMER, runner MSOG from JIPMER and Pondicherry. Conducted workshops in an international forum, Sri Lankan Obstetric Society. Yeah, over to you. Take over the session, Dr. Rajapriya ma'am and Aruna Ashok, and introduce the speakers for the day.
Thank you, Dr. Meena, for coordinating. We are very happy to start academic doctors. So this is yeah, your unmute panel. It's there. Yeah. So very happy to have the first reproductive health committee webinar. So happy to invite you both doctors.
Thank you,
They
ma'am.
readily accepted it despite their vacations. So Dr. Puvitra Tanikachalam, she's a senior consultant, fertility specialist, andrologist, and head of the Department of Chettinad Fertility Services. And this is her academic contribution. She is evidence-based medicine being the core strength. I think she is also contributed to so many papers and even authored some books and edited Spirov's Clinical Gynecology, Endocrinology, and Infertility. Very happy to hear you from you, doctor. The next slide. Yeah. And we also have Dr. Bharati, who is the founder and medical director of Bharati Fertility Center located in Mandavali, Urapakam, Ambattur, and KK Nagar. She has finished her MBBS from Ramachandra, MSOG from Ramachandra, reproductive medicine fellowship from Triple M, and she's having 18 plus years experience. And over to you, doctors, to discuss and let us know some new points in PCOD. case profiles. We made this discussion in such a way that we'll not talk theory, and we'll have case profiles and case discussions, so that when the practitioners listen to it, they're already flooded with knowledge nowadays. So we wanted your experience from your patients so that it will be helpful for them to follow it.
Thank you, ma'am.
Thank you. I think we can stop. You can. Are you able to share your screen?
Yes, ma'am, we checked. We're able to share the screens.
Dr. Bharati, you're going to do first?
Ma'am, she can start
Yeah.
now.
Yes.
Ma'am can start.
Okay, ma'am.
Yeah.
I'll share my screen and I'll start it. So, அனைவருக்கும் வணக்கம். I'm happy to be part of this webinar today. So, Dr. Aruna had invited me to share some case scenarios on ovulation induction. The thing is, since we are not a standalone fertility center, most of the times patients for ovulation induction come to us after they've had many cycles outside. And they come to us after many years of infertility. So let me go into the first case scenario. So I had everybody is able to visualize my slides, and am I audible?
Yeah, ma'am.
Pavitra, can you make it slide share mode?
Sure, ma'am. Yes. So the first couple, I'll just check this. Yes. So this was a 26-year-old woman and a 30-year-old man. The woman was a teacher and the husband was an accountant. They were married for 4 years and it was a non-consanguineous marriage. She had 2 miscarriages earlier before she came to us. And when she came to us, her duration of infertility was for a period of 3 years. She attained her menarche at 13 years of age. She had regular cycles till 18 years of age, and then her cycles became irregular. That was once in 50 to 60 days. She had spontaneous cycles, but the cycles used to last for a longer duration, and she had to take hormone pills in some cycles, and she did give a history of menorrhagia. So for the last 4 years, she's been having only induced cycles, even if she does not get cycles for, like she may not get cycles even for 3 to 4 months at a stretch. And then she'll take progesterone for induction of the withdrawal cycles. So coming to her obstetric history, soon after marriage, I mean 8 months after marriage, they had met a doctor and ovulation induction was done. She required only oral ovulogins, no gonadotropins were given. Beta HCG was positive at 6 weeks. Then ultrasound scan at 8 weeks showed a gestational sac of 7 weeks size. Fetal pole was not seen. And the doctor had advised MTP for her. And MTP was done. After 3 months, again, she had tried 2 cycles of ovulation induction, required gonadotropins. And then later in 2019, in the second cycle of ovulation induction, she conceived again. Beta HCG was positive. The sac fetal pole with cardiac activity was seen at 7 weeks. But then she had bleeding again after a week, and she had a spontaneous complete miscarriage. So since then, again, she had only irregular and induced cycles. Few cycles she was given combined oral contraceptive pills for cycle regularization. She gave a history of weight gain of around 10 kgs from 2018 to 2022 when she met us. Since she had 2 miscarriages, she had undergone certain investigations even earlier. All these investigations turned out to be normal. In 2021, again, she had few cycles of ovulation induction with gonadotropins. In between, there was the COVID, and except for cycle regularization, she did not take any other treatment, much treatment. So then 2021, few cycles of ovulation induction was tried with gonadotropins. There was no follicular growth. And the clinician had suggested a diagnostic laparoscopy for her. In 2021, diagnostic laparoscopy with ovarian drilling was done. Both her tubes were patent. Following the diagnostic laparoscopy and ovarian drilling, she still had only irregular and induced cycles. In 2021 and 2022, she had 3 cycles of ovulation induction, tried with gonadotropins post-ovarian drilling. Or at least 7 to 8 doses of gonadotropin, 75 international units was given. They've tried both urinary and recombinant gonadotropins, but there was no follicular growth. So she presented to us in 2022. She still had irregular induced cycles. Her BMI was 28. The transvaginal ultrasound showed a normal uterus, bilateral polycystic ovaries. And as we always do, She was a young patient. She was just 26 years old. And we know that she's been having resistant PCOS. She's not been responding even to gonadotropins. So the first step of treatment, as we always say, is weight reduction. We explained in detail to her about the risks with this increased BMI, with the weight gain of 10 kgs that she's had. And we explained to her, it's not just the fertility, but it is also the antenatal risks which will be increased. Because as far as we know, she's had 2 miscarriages with no other test positive except for the higher BMI. So we did tell her that weight reduction might help her. So the patient, we gave her 4 months time. We gave her a proper plan that in 4 months, if she loses weight and she can try to conceive again naturally, if she conceives, well and good. If she does not conceive, then we'll go back to ovulation induction again. So the patient reduced 7 kgs in 4 months with low carbohydrate diet and strength training exercises. Cycles were still irregular when she came back to us after the 4 months. And we counseled in detail about the ovulation induction plan. Again, in any resistant anovulation or any patient with anovulation, if we are going for ovulation induction, we generally counsel the patient. We'll tell them that we'll go step by step. We start with a very minimal dose. We'll try giving just oral ovulogins initially, and then we will include gonadotropins. She is a patient who has already been resistant to gonadotropins. So if she had come to us directly and if we had decided to not go with weight reduction, or if she's not reduced weight in this 4 months, then my plan would have been different. I would have given her oral ovulogins and I would have started the gonadotropins even earlier in the cycle. But then since she's reduced 7 kgs, again, I did not want to take the risk of multiple follicular development or OHSs. So in case her ovary responds differently because of the 7 kgs weight loss, so I started off, I did a hysterosalpingogram because she had a laparoscopy earlier and ovarian drilling. Cavity was normal. And I also wanted to look at the cavity because she had 2 miscarriages. So cavity was normal and bilateral patent tubes. So, and we did ovulation induction with letrozole. Again, I prefer giving letrozole when I suspect that the patient might require gonadotropin addition because of the shorter half-life of letrozole when compared to clomiphene. I think that multiple follicular production and the risk of OHSs may be lesser when I combine letrozole with gonadotropins. So with letrozole 2.5 milligram twice a day, I gave it from day 2 to day 6 of the cycle. I did an ultrasound on day 7 of the cycle. There was no follicular growth. The endometrium was also quite thin. Then I added urinary HMG, 75 international units on day 7 and day 9. Then on day 11, I did an ultrasound and I saw 11 millimeter follicle. The endometrium also started becoming trilaminar pattern, showing trilaminar pattern. Then I gave another dose of urinary HMG, 75 international units. Repeated, when I see a follicle growing, I prefer giving gonadotropin on alternate days. So until the follicle reaches above 14 millimeters. So once the follicle crossed 14 millimeters, so the scan when I saw 16 millimeters follicle, I stopped the gonadotropins. I allowed the follicle to grow by itself. Then when the follicle reached around 20 millimeters, I gave a trigger with urinary HCG, 5,000 international units, and advised timed intercourse. We advised her to continue folic acid. Generally, for ovulation induction patients, I give only folic acid. So I do not give any progesterone luteal support. Her pregnancy test turned out to be positive. And then any woman with longer duration of infertility, I always prefer doing beta HCG. Beta HCG values were good because I think that it is important that we try to rule out an extrauterine pregnancy earlier. So I did beta HCG also and monitored, and then beta HCG levels were good. So then she went through routine antenatal care. Antenatal period was uneventful. She just had mild anemia. She required only iron tablets for that, step up the dose of iron tablets. She had a term normal vaginal delivery. The birth weight of the baby was 3.1 kg. Mother and baby were well. So this is my first case. So shall we have a discussion after each case, or is it going to be after both cases, Dr. Aruna? Dr. Bharati?
We can have after each case. Dr. Bharati, are you on?
Yes, Dr. Bharati?
Yes, ma'am.
Do you have any points to discuss in this case, Dr. Bharati?
Ma'am, one second, ma'am. You're able to hear me, ma'am?
Yes, ma'am, I'm able to hear you.
Yes. Ma'am, why did you use urinary HMG, ma'am? You regularly still use urinary products?
Yes, ma'am, I am very comfortable with urinary HMG, ma'am.
Okay. So for all patients with ovulation and induction and timed intercourse, you're using only urinary HMG, ma'am, even if they're PCOS or anything.
Yes, even if there is, I generally do not do the FSH and LH levels or serum AMH levels. I go with my ultrasound findings. And
Okay.
even if the FSH and LH was done elsewhere, and if they come with altered FSH LH ratio, I still prefer giving urinary HMG, ma'am, because evidence also says that there's not much difference there's no difference when compared to urinary HMG and recombinant FSH when it comes to ovulation induction. So I prefer using urinary HMG, ma'am, especially in all my ovulation induction cases. ART, of course, I try to combine recombinant and urinary HMG or just urinary HMG. But for ovulation induction, I go only with urinary HMG.
And ovarian drilling, ma'am, do you regularly do drilling when there is
This is done elsewhere. I've never done ovarian drilling, and I've never recommended ovarian drilling for my patients also, because as we see in this patient also, and I just try to, collect data from most patients who underwent ovarian drilling elsewhere and they came to me after ovarian drilling. We found that, when the lifestyle modification did not happen, or when they did not lose weight, and they went back to the same pattern of irregular or induced cycles, and their fertility did not improve much. And we have a lot of studies which also say that CC gonadotropin combination gives equally good results. The only worry is multiple follicular development when it comes to gonadotropin administration. But if we go step by step with a low dose, I think we can avoid that multiple follicular development. With laparoscopic ovarian drilling having the complications of reducing reserve and adhesion formation, I am not very comfortable suggesting ovarian drilling for my patients, ma'am. This patient had it done out elsewhere before she came to us.
I'm just a discussion. How patients are they comfortable coming every alternate days for scan? I'm just asking you.
Yes, ma'am. Yes, when we explain to them that I have to monitor closely,
Mm.
they are willing to come, ma'am. And I think it is more about the charges. We have a fixed package. The number of scans, it doesn't matter. Even if they have more number of scans, they just pay the same amount. Because why I'm saying this is most of the times patients do ask us this doubt, because in some scan centers, when they go for follicular studies, they say only 3 scans are included, only 4 scans are included in one follicular study, then they have to pay another package. So when we tell them that it is not that way, then they're usually comfortable. And I think counseling them is more important, ma'am. Especially when I put them on gonadotropins, I do want to monitor them closely. One is to see if there is a response. The next thing is to see if there are multiple follicle development. I do not want multiple follicles in an ovulation induction cycle, ma'am.
Yeah, I think when we start on gonadotrophins, multiple follicular monitoring is needed. Only if oral gonadotrophins are given, I think we can monitor less frequently. But when gonadotrophins are given, we have to monitor, and particularly when low dose step up and all we are using, we need to ask them to be comfortable coming and going. I think that's where the problem is starting nowadays. But we have to have a comfortable timing and package so that the patient also feel comfortable coming.
Yes, ma'am.
Very nicely managed. Just a
Yes.
point on ovarian drilling.
Yes, ma'am.
What nowadays everybody in the meetings and everybody wants to deny ovarian drilling. But when I'm a young girl, 25 years, lean PCOS with a severe PCOD, and there is a tubal block where I'm doing a laparoscopy for the patient, I think instead of putting the patient on gonadotrophins, because if I don't do a laparoscopic drilling at that time, the patient is again going to have irregular menses. Further follow monitoring and everything. If there is an indication and the patient is a candidate fitting into ovarian drilling, not for a 35-year or a more than 30 years patient, but for a patient who's younger than 30, and there is a tubal factor which you are going to correct or a cyst which you are going to remove. And at that time, if she is a PCOD, I think doing ovarian drilling is only in this scenario, in this present scenario, only option in these cases where you are doing a laparoscopy for some other condition and the patient is also having PCOD and she is not willing to come often for a scan. then ovarian drilling do play a role, minimal role in these sittings, but very hardly. Over the last 1 year, maybe 3 or 4 cases maximum we would have done ovarian drilling. But not previously it was the rule, but nowadays nobody is doing it. But these scenarios will definitely make a patient comfortable. We had a patient coming 20 kilometers from Kanchipuram. So we did ovarian drilling and asked her to just follow metformin for 3 months and then try it. She conceived. So it makes her happy and not to visit the doctor often. This is 1 or 2 scenarios where you can try it. Though, as we perfectly understand, we should not do it regularly for all the patients, and we should not do it only for vein drilling. You're doing a laparoscopy. That is also not a good practice to follow.
And one more question. How convenient are you in counseling a patient for weight reduction? I mean, how many patients do successfully reduce weight and come? Or you deny treatment to them just because they're not losing weight? Or...
Ma'am, see, I would say that I can say that at least 80% of my patients, once I spend time explaining to them, not just about the fertility, ma'am. If I tell them you lose weight, your cycles are going to become regular, then they say, you do treatment, I'm not going to lose weight. You do the treatment and you make me pregnant. But when I tell them the risks during the antenatal period, when I tell them that the risks of miscarriage, you go through so much, you do all the treatment, you don't lose weight, you get pregnant, your risk of miscarriage, your risk of GDM and all of this is going to be higher, then most of the patients agree, ma'am. At least 80% of my patients do lose weight. I monitor them continuously. But then again, it is important to know how much time I can give for each patient. So that again depends on their age, their duration of infertility, their previous treatment and all that. If it is a younger patient, less than 30 years of age, I would definitely give them at least 5 or 6 months. I'll tell them, see, it is good for you. So if you lose weight and come back, and if I explain to them regarding the antenatal risks, their long-term health risks with not losing weight and everything, 80% of my patients do comply to it. I've had, during the 6 months of weight reduction period, I've had long duration of infertilities, like 5 months or 6 months of, 5 years or 6 years of infertility with irregular cycles, not conceiving, and then conceiving spontaneously with weight reduction and, like regular cycles and weight reduction and then conceiving spontaneously. So as I said, it is also about having a healthier pregnancy. So I always take enough time to go through detailed diet and exercise advice. And I do not do this in Chettinad, but of course in my private clinic, I give them incentives. I give them a discount if they lose weight when they come in the next visit. So it is more like a motivation. So I tell them that if they lose weight, I keep monitoring. So most of the patients comply, ma'am. If we explain, they do it.
Okay. Thank you, ma'am.
Thank you, ma'am. Can I go to the next case, ma'am?
Yes, ma'am.
Yes. So the second couple, both of them were 36 years old. She was a homemaker and the husband was an electrical engineer. They were married for 6 years. When they came to us, it was a non-consanguineous marriage again, primary infertility. I'm sorry, this duration of infertility is 6 years. I made a mistake here. I'm sorry. So she attained menarche at 11 years of age. She had regular cycles till marriage. And she had irregular and only induced cycles for the past 6 years after her marriage. So she had a weight gain of 5 kg in the first year of marriage, and she's been maintaining in that weight since then. So that is when I usually ask the history of weight gain, ma'am. When they say they started having irregular cycles, I ask them the history of weight gain, and we generally see that most of these women, irrespective of their BMI, they would have had some amount of weight gain, and following which they would have developed irregular cycles. She was an athlete during school days and college days. So once she got married, she stopped all the physical activity, and that is when she gained weight. So 2016 to 2018, she had multiple cycles of oral contraceptives for cycle regularization. All this was done elsewhere. In 2018, she was diagnosed with an endometriotic cyst. So she underwent laparoscopy, adhesiolisis, and endometriotic cystectomy in the right ovary with bilateral ovarian drilling, bilateral patent tubes. 2018 to 19, she was given ovulation induction with letrozole 5 mg from day 2 to day 6. This was also done elsewhere in a clinic, followed by dydrogesterone 10 mg from day 16 to day 25. So this was done for almost 7 to 8 cycles without follicular monitoring. So during those 2 years, we do not know, those 7 to 8 cycles, we do not know if she developed a follicle. So she was very happy though that she actually had regular cycles. But that is actually because of the withdrawal, the progesterone withdrawal. And in 2020, ovulation induction was done with oral ovulogins. Clomiphene 100 was tried. Letrozole up to 7.5 milligram was tried. Elsewhere, there was no follicular growth. Then at one particular place, she had clomiphene 50 milligram for 5 days and recombinant FSH of 150 international units, 5 doses. She developed OHSS because she was not developing a follicle with 75 international units. They had stepped it up to 150 international units, 5 doses. And then again, 22, she, after the OHSS episode, she was very scared to go back for fertility treatment. And 2020 to 2022, she did not take any treatment. She did not take combined pills or anything else. Whenever she had menorrhagia, she visited the doctor after, like 3 or 4 months of amenorrhea, then she'll have menorrhagia, she'll visit the doctor, she'll take progesterone. And this is how it was going. So when she presented to us in 2022, she had only induced cycles. Her BMI was only 22. It was well within the normal limits. But as I said, she's had some amount of weight gain. So probably that is what, resulted in these anovulatory cycles. In a transvaginal ultrasound, her uterus was normal. Both ovaries were polycystic. The right ovary had another it had 2 endometrioma, one 4 centimeter size and then one was 2.5 centimeter size. So we had advised ART, mild stimulation protocol, in view of her advanced age. She was 36 years old and she's had multiple cycles of resistant anovulation. And with 75, she had international units, she had anovulation and she had previous history of OHSS. She had already undergone bilateral ovarian drilling. She had undergone cystectomy for endometrioma. So we said we'll go ahead and do an ART. But she was referred by one of my patients who had similar history of resistant anovulation and she conceived with ovulation induction. We tried telling her that each and every patient is different, but still she was not willing for ART. She wanted to try at least 1 or 2 cycles of ovulation induction with us. So we did counsel her. We told her that, we may have to cancel her cycle if she had OHSS or if she had multiple follicles. After counseling about all of this, then we did started the ovulation induction. I did do a hysterosalpingogram again for her. She had left tube, she had distal block, but her right tube was patent. So I told her on ovulation induction, again, I told her that she has to do some lifestyle modification for 2 months. So again, exercise and diet advice was given. And I told her that we'll try 2 cycles of ovulation induction. I did have a plan, depending on whether she's losing some weight or not. And then if no follicular growth, I said I'll plan ART and she was okay with that. So the first treatment cycle, when she came back to us, she had lost only 2 kgs, but still I wanted to start with, because she had OHSS earlier, OHSS is one scary thing. So I started with letrozole 2.5 milligram twice a day, day 2 to day 6, but I started urinary HMG earlier. I started from day 2 and I gave it on alternate days, day 2, 4, 6. And on day 7, I did an ultrasound. There was no follicular growth. The endometrium was very thin. I repeated the urinary HMG doses again, day 7, day 9. Then I started giving it continuously, day 9, day 10, and day 11, combined with follicular monitoring. All the follicles were very small. There was no sign of even a growing follicle. So then I discussed with her. I told her that, see, I had initially tried doing this. If this didn't work, so but I wanted to plan a chronic low dose step-up protocol because earlier for a similar patient, chronic low dose step-up protocol had worked. So then I canceled the cycle. I again rechecked with her about her willingness for ART, but she, as per the plan, she wanted to stick to 1 more cycle of ovulation induction. So in the second treatment cycle, I followed the chronic low dose step-up protocol. In the chronic low dose step-up protocol, I've not done this many a times, probably I would have tried this for 3 or 4 of my patients. And I've started only with 37.5 international units. I started 37.5 international units day 2 to day 8. Then I did an ultrasound on day 9. There was no follicular growth. So I stepped up the dose to 75 from day 9 to day 12. Generally, the chronic low-dose step-up protocol, they say give for 1 week and monitor. But since she had an earlier history of OHSs, I gave only for 4 days. I monitored again on the next day, the 5th day of 75 international units. So on day 13, that was day 13, and I saw that in the right ovary. So along with the endometrioma, she had this follicle which was bigger than the other follicles. So which looked like a probably growing follicle, 9.5 millimeters. So I didn't want to step up the dose now. So, and it was just 4 days of 75. Then generally the consensus says that you give for 7 days, and only if after 7 days, if there's no follicular growth, then you step up the dose. So 4 days, one follicle looked like a probable follicle. So I continued the same dose for another 3 days. Then I rechecked the ultrasound. The follicle was growing good. I had a single follicle around 14.5 millimeters. The endometrium was also beautiful, trilaminar pattern. And then but 14.5, after all these multiple doses with 14.5, I did not want to stop. I've done this earlier, not in a chronic low-dose step-up protocol. One patient who required gonadotropins, when I saw 14 millimeters follicle, I stopped, and then the follicle regressed. So I'm a bit skeptical about stopping at 14. So I would be happier if it goes at least up to 15. So the next scan I did, the very next day, after giving another dose of 75 international units, and the follicle reached 16 millimeters. The endometrium was also beautiful. So after 16 millimeters, I stopped the HMG. I continued monitoring. And on day 21, she had a beautiful follicle, 20 millimeters size with trilaminar pattern. Trigger was given 5,000 international units of urinary HMG and advised timed intercourse. Continued folic acid as usual. Again, pregnancy test was positive. She did have impaired glucose tolerance during pregnancy, but that was managed only with lifestyle modification. She did not require she did not require metformin or any other insulin or anything else. No treatment required. And she had a term normal vaginal delivery. Birth weight of the baby was 3.2 kg. Mother and baby were well. So this is the second case. And Dr. Bharati, I'd like to hear from you.
You're able to hear, ma'am?
Dr. Bharati, yes, I'm able to hear you now.
Yes. Ma'am, this chronic low-dose step-up protocol, do you routinely practice, or since the patient insisted you have done this, ma'am?
So especially in somebody with the previous history of OHSs, I would not have done, ma'am. I would have gone for ART, resistant anovulation, long duration of infertility. I would have definitely gone for ART with mild stimulation.
Yes.
But the patient insisted. So as I said, I've tried only, for 3 or 4 patients, not more than that. In these last 10 years, I tried only for 3 or 4 patients, ma'am.
Okay. I think, ma'am, anybody wants to ask?
Beautifully managed. Very happy to see. I think the patient would have been very happy that she did not undergo IVF and conceived with normally. Chronic low-dose prep-up, I think Sonal Panchal and Nagori team has done extensive work on that. And we also feel that instead of starting from day 2, what we have modified from their advices were give letrozole for 5 days, and after finishing letrozole, then you start the gonadotropins, especially if you're PCOD instead of HMG. There's no difference is what they tell, but what we found was the number of days of stimulation is reduced when we give RFSH or urinary FSH, whatever you're going to try. So we generally give RFSH 37.5 for 3 days and then call her again. And depending on that, with the blood flow and the follicular monitoring, maximum doses of 37.5, which we required is 7 days, as she told. Very rarely now we are requiring 75 IU, and the success rate is very good with RFSH for these patients. Maybe the number of days of stimulation and number of doses will reduce, and ultimately the cost is the same. So that's the only input from us, but it's very good to hear from the cases. I think the topic is been done justice by your presentation. Thank you.
Thank you very much. Thank you to the entire team. Yes, ma'am. I'll stop sharing my slides. Dr. Bharati can take.
Excellent cases, Pavitra.
Thank you, ma'am.
Excellent presentation, Pavitra.
Thank you.
Should I start, ma'am?
Yeah, start, Bharati.
1 second, ma'am. Yes, ma'am, 1 second. The first case scenario is actually an infertility management in a couple with obese PCOS.
Bharati, can you make it full screen?
Pardon, ma'am?
Can you make it full screen?
Ma'am, it's full screen only, ma'am.
It's coming. Please make it slide share mode, no? There is a hourglass appearance in the bottom, no? Go to that and click.
Now, ma'am?
No, Bharati.
1 second.
There is a symbol like a hourglass, like a cup, cup, no? At the bottom. Take the help from the person who's sitting next to you. You know?
No, ma'am,
Ask
actually,
him to
no. In this particular system, it's not coming. I don't know. It should come. It's not coming. I'm also searching.
just close it and redo that.
Okay, ma'am. Okay, ma'am. 2 minutes, ma'am. Okay. Sorry, ma'am.
Now it's full screen, ma'am.
Yeah, it's fine, Ra. Yes, Da.
Yes, ma'am. Yes, ma'am. Good afternoon, everyone. Thank you for giving me this opportunity, Oxy. So my first case scenario will be on infertility management in a couple with obese PCOS, totally different from what Dr. Pavitra presented. This patient is to 33-year-old ma'am and her husband is 34 years. They're married for 5 years. They came to me with irregular periods, like 5 to 6 cycles, 5 to 6 days of cycles for every 60 days and only induced cycles. And she was already diagnosed with, she was a known case of PCOS. Her BMI was around 34.5, AMH was 9.9, and TSH was 2.18. Ma'am, I routinely do AMH for, if there is a PCOS, I routinely, along with the antral follicle, I also see the AMH, ma'am. And then her blood sugar profiles were within the normal limits. And in the scan, she had bilateral PCOS. On the right, the AFCs were around 18 and the left were around 15. And tubal evaluation was already done and it was normal. And the male partner count was non-ozoospermia. Am I going slow or am I fast?
Fine, Ra.
Fine,
Excellent.
fine. And then her initial, her treatment history outside, she had like 4 cycles of ovulation induction with timed intercourse, and she was given 3 cycles of myoinositol and chiroinositol combinations. And then later on, she had even 3 cycles of IUI. This previous ovulation induction, she had it with letrose with gonadotropin combination, and every cycle the follicle grew, and then there was a rupture documented, and she didn't conceive. So they had done IUI 3 cycles, which again was all the scans were documented. There was a proper growth of the follicle, rupture, endometrium was fine, everything was fine. So after all these treatment, patient came to us and she wanted ICSI straight away. So we proceeded with ICSI because already she was in a weight loss program for almost 10 months, and from BMI from 34 came down to 33 now. So in fact, we counseled her for all the complications for her weight loss. We advised her to take time and go for gym and all the other lifestyle modification, but she was not interested and she was keen on proceeding for IVF. So we went with the antagonist protocol, and we used recombinant FSH, and in the later cycles we added HMG, and the duration of injection was 10 days, and we triggered her with decapeptide 0.4. So this is the chart. So from day 2, we usually monitor the LH and E2, and the follicles where AFCs were 18 and 15. We started with a dose of FSH of 300, and then after giving it for 4 days, we scan on the 5th or the 6th day. Since she's a PCOS patient, I called her in for day 5. And I mean, usually the later half of the cycle, I add HMG along with FSH to mimic the natural cycle. And then the dose was modified to FSH 225 and HMG 75, and Antag was added. And then at the end, her follicles, when it became dominant to 19, 19, 18 and everything, we triggered her with decapeptide trigger. I don't usually use combined. I don't use this combined HCG or only HCG. I am comfortable with decapeptide trigger. Anyhow, we are only going to freeze the embryos. We're not going to go for a fresh transfer. And expected follicles were around 20. Retrieved oocytes were 25. Mature oocytes were 17, but the quality was average to poor. Sperm was normal. Despite large number of despite we got many follicles, the oocyte quality was definitely a concern. And M2 was 17. The fertilized were 15. Cleaved were 13, and blastocysts frozen were 9. In that, we got grade 1 blastocysts were about 5. So this is a picture of the blastocyst we got. And ET was embryo transfer was smooth. We transferred grade 1, 3A and 4A embryos, and endometrial thickness was 9, and all luteal phase supports were given. And she was positive. Her beta HCG was 234, and repeat was 592. And then she delivered a 3 kg baby. Abgar was 8 by 10 and 9 by 10. Before the transfer, she again went into a weight loss program, and then she reduced to say about 4 to 5 kg. She couldn't reduce more than that because she's always been obese throughout. So, but anyhow, we delivered her by LSCS, and postpartum period was uneventful.
Yes, Dr. Bharati. So that was a good case. So I understand that after multiple ovulation induction cycles and after 3 cycles of IUI, she's almost like a case of unexplained infertility, where if we do 3 cycles of IUI and she doesn't conceive, and then yes, of course, we have to move on to ART. So, so you do ANTAG protocol for all patients or only patients with multiple follicles, madam?
Antag protocol is what I'm routinely following, ma'am. Of late, for the donors and PCOS, I have tried using this progesterone primed protocol, because which is trying to be little cost effective. I've tried with donors, and 1 or 2 patients who are not able to afford, we tried even this progesterone primed protocol, ma'am. Like we start Meprate 10 milligram from the day 2 up to trigger. Likewise, we monitor all these levels, and since it's a freeze-all program, it kind of works out to be little cheaper than the anti program. But only thing is we have to make sure that the patient takes the tablet every day. So we call the patient here every morning, and we make sure we ask we put the tablet into the patient's mouth, and then we give the injections. Now, this is what I've been trying off late, and it seems to work.
Okay, ma'am. So I understand that this is a frozen embryo transfer cycle, and what was the protocol, madam? Ovulation induction or the HRT? You followed HRT.
HRT only, ma'am. HRT only. Definitely HRT. Like I gave her like 2 to 3 months gap for her to lose the weight, and then we did a HRT program, and then we transferred the embryos.
Okay, madam. Okay. Dr. Aruna and the participants, if you have any questions, you can put it up in the chat box.
It seems it is a good case, and I think successful pregnancy. Anyways, you manage, and the patient is comfortable. We are also happy to hear. I saw the LH was very less on the day of trigger. How comfortable are you when the LH is so low to give only agonist trigger? Because there are reports, case reports, that when the LH is very low on the final day, you can get a response to decapeptyl might be low. Not that everybody, because the time that you test LH and how the diurnal variation all matters. But
Yes.
have any time you have modified your trigger based on LH, or is it the same depending on only on the number of follicles you decide that trigger?
No, ma'am. Initially, I was actually keeping into this account of this LH, and I was giving a dual trigger. But when I compared my patients, this LH, this low LH and dual trigger, and this low or any LH with this decapeptyl, I didn't have any difference in the number of oocytes retrieved or the quality or the matured oocytes. So it was my own
Okay,
own
good.
optimization of cases that I didn't find any difference even when the LH was low or high that I needed to add HCG along with it.
Do you do double trigger like next day? There are doctors who are giving decapeptyl again the next day. Do
No,
you do like that?
no, ma'am, and I don't even monitor because I don't call them the next day. I don't check the LH. This I'm not doing it, ma'am. Though I know many doctors after giving decapeptyl trigger, they call them after 12 hours to check the LH and to see whether they have responded. But all these 6 years, I got one case of OHSS, ma'am. After that, I am in no mood to go for a dual trigger or in no mood to go for a straight HCG trigger. This has worked out for me even when there is a low LH. A couple of times
Okay,
I checked the LH and it has worked out, ma'am.
good. Nice presentation. Theory we would have heard so many times, but when you discuss the case scenario, it gives us lots of insight on how you managed. And I think you
And
are
here,
having another case also, or this is
yes, I have another case. Ma'am, here I just want to
okay.
highlight one thing that instead of giving this anti, we can go for this progesterone primed uh, protocol, which is actually helping us out in terms of the cost. And for
Yeah,
me, PCOS, instead of using HMG, I have better results when I'm using recombinant FSH because I definitely feel the recruitment is better using an FSH.
yeah, definitely. The number of injections also can come down. I think with elagolics, this there can be a game changer that we can be more comfortable giving even antagonist as a tablet. I think there'll be more studies coming up with elagolics as antagonist used for ovarian stimulation. So we'll wait, and we can also do the trial and publish. I think we'll move on to the second case if there is no questions.
And do you always add HCG, ma'am? If the LH is low, 0.29, you give a dual trigger or you give only HCG?
Yes,
Yes.
we whenever the follicle E2 or the follicle is more than 20, we don't take that risk. We check the next day LH and see. How we monitor is if the LH is less than 2 is the criteria. If the LH is less than 2, then we give a decapeptyl trigger. And the next day morning LH, if it is more than 30, I'm very comfortable. I need not be worried. If it is low, then we add a HCG 2000 or so to have a and reduce the number of what to tell low M2 patients.
Ma'am, but you don't have to check it, ma'am. You can take it from me. You can go ahead with it.
Yeah, but these are the patients who have come already with empty follicle, already with IVF failure.
Then
We
we need,
cannot take
yeah.
that risk, right?
Yes.
Yeah.
Okay,
This
ma'am.
is all, most of the patients nowadays are coming with a failure and things. Maybe you're lucky that you've not got it, but we have
Ma'am,
seen patients where the LH low, and particularly when the previous cycle OC pills and the complete suppression was given in many centers. No, when the patient has taken OC pills, particularly when the donors, one or two patients at least happens 6 months once, because the donors are given OC pills in many centers and they come back when we stimulate and we give only agonist trigger to the donor, we get very low number of
I'll start the next case.
decapitate because we don't monitor the donors LH and all. It's too much to monitor the donors for all these blood tests. I think you're lucky in all the ways. Stay lucky. Thank you.
Thank you, ma'am.
Ma'am, how about the progesterone protocol, ma'am?
Ma'am, progesterone protocol is from you can actually I'm giving Meprate, ma'am, but there are studies where you can give Dufestone also. Like you start from day 2, you give Meprate 10 milligram, ma'am, up to the day of trigger.
Okay. Okay, ma'am.
Instead of giving antagonist.
Instead of giving antagonist.
Yes. And you stimulate them as usual and check the LH and E2 as usual. But you should make sure that they take the tablet. That's what madam said. Antagonist may come as a tablet.
Okay, okay. Thank you, ma'am.
I'll go to the next case, ma'am.
Yes, doctor. Yeah.
Ma'am, this is a patient with 29 years and her husband 39 years, married for 5 years. Came to us with primary infertility, and she came to us with 90 days of amenorrhea. UPT test was done, it was negative. She's having irregular cycles. Her BMI was around 33.1, and she's a hypothyroid, taking Tylenol. And she's on ultrasound. We found her to be having bilateral polycystic ovaries, right ovary around 20 follicles, and left ovary around 20 follicles. And her AMH was around 10.14, which is on the higher side. And TSH was 13.78, and she was taking Tylenol for that. And AFC 2020 and tubal patency was done by SSG, which was turned out to be normal. The semen analysis, he had acinoteratospermia and antioxidants was prescribed for 3 months. She had multiple cycles of ovulation induction with timed intercourse outside, almost 7 cycles, and everything failed. And then when she came to us, we planned for an IUI. It was an ovarian, we gave her Letrose, and along with Letrose, like I give Letrose from day 2 to day 5, and then on the 5th and the 6th day, I gave her FSH, 75 international units. And then when I called her on day 8, the follicle was only 10 mm and 10 mm, and endometrium was 5 mm. So I added one more dose of 75 international units of HMG, and then called her on day 10. Again, it was only 12 mm. Then I added one more 75 international units, and then it became 14.5. And on the 15th day, we added one more 75 international units, it became 18. And then we called her on day 20 of the cycle. The follicle size was 20 millimeter and endometrial thickness was 9 mm. And I gave her only a decapeptide trigger. And then sample IUI processing was done and luteal phase support was given. And beta HCG was 1297, doubling was there, and confirmed through a scan. And she delivered a normal, she had a normal delivery, ma'am. The highlight is married 5 years, obese, 33 kg, AMH was 10.14, severe PCOS, male factor was acinoteratospermia.
Yes, ma'am. Thank you very much. This was a nice case presentation. So, do you regularly use only letrozole, ma'am, for ovulation induction, or do you use clomiphene citrate also?
Ma'am, for PCOS, I prefer using letrozole, ma'am, not clomiphene citrate. I prefer using letrozole because it's you get a single follicle recruitment will be there. You can prevent OHSS and endometrial thickness will be better. So I am routinely using only letrozole, ma'am.
Okay, ma'am. Okay, ma'am.
Letrozole with gonadotropins is what I follow. Instead of starting straight away with gonadotropins, I prefer using letrozole with gonadotropins where the pregnancy rate is also better instead of using only letrozole or instead of using only gonadotropins.
Dr. Arna?
Can you tell us what all letrozole regimens you follow, or only the fixed 5 days regimen that you follow?
No, I'm following only the fixed 5 days regimen. I give it from 2 to 5 milligram, 2.5 BD or 5 milligram per day.
Okay.
And then the 5th and the 6th day, I add the FSH.
Okay. Regarding the adjuvants that we use for PCOD, metformin, myoinositol, nowadays berberine extracts are coming. What is your comment, both of the doctors? How often you're using metformin, or which of the patients you use metformin, myoinositol, or whatever supplements you're using for PCOD, apart from lifestyle?
Metformin I use only if her sugars are not normal, ma'am. She has impaired glucose tolerance. I use metformin. I don't use myoinositol or decairoinositol. I give them only metformin, and only if she has impaired glucose tolerance.
Ma'am, I'm giving them myoinositol, decairoinositol combination for 3 months, ma'am. Along with my along with ovulation induction time, the glucose I'm using. Like ma'am said, metformin only if there is a glucose intolerance. Otherwise, not routinely metformin.
Are you categorizing the patient of PCOS into the four phenotypes and modifying the drug therapy based on that, or it's only theoretical and only for to know the complexity of the issue, we have to have the phenotypic variants? How often we are using the phenotypic variants of PCOS in our clinical protocol?
As specialists, I think our concern is more about the ovulation part, but still, as you said, we do see that patients who have like hyperandrogenism, they do react differently to our treatment. We do see that, but again, I do not, my treatment protocol does not differ depending on that. I go with the lifestyle modification and then ovulation induction. So that is how I go with it.
For example, hyperandrogenism is there, hirsutism is too obvious. Then those patients, do you think this metformin or checking any other test should be done to rule out high levels of androgen, or you will advise something to reduce the testosterone levels and indirectly the LH levels too? Or you don't monitor LH and you don't want to suppress LH in any ways?
I don't monitor LH, ma'am. I mean, it will always be constantly high for this PCOS women. So it does not give us any idea about that. LH is not going to determine what is going to be the dose or the treatment. So monitoring LH
is not needed. And for any patients in PCOD, do you add DEXA at any situations? Dexamethasone to in a resistant cases with hirsutism, does it help you, or you don't want to use it?
Ma'am, actually, there's no evidence to support it, but yes, there are centers or there are hospitals using it, and they say it helps. But personally, I have no experience, ma'am.
And we do see, as you said, we do see with patients with a lot, extensive hirsutism with a lot of acne, we do see that they still respond really well to just clomiphene 50 milligrams. So it is so different, ma'am. Each and every woman, each and every cycle, it is so different. So whether monitoring these or basing go changing the treatment depending on this, I don't know how helpful it is going to
We're
be.
using DEXA, ma'am, for all and monitoring LH, ma'am, for all patients.
No. We don't do that, but we see the prescriptions of DEXA. But we do use it for patients when they're very resistant, even after Folisurge or RFSH 37.5. Then towards the fag end, it will reduce the days that is needed. For 5 days or 6 days, we have used for certain patients and they have conceived beautifully. But maybe if you take in a year, 4 or 5 patients, it's like that.
But not
So
routine.
and last but not the least, one question for Dr. Puvitra, who was doing what is the specific lifestyle that you will tell for a PCOD patient? Because they are not the normal patients who will reduce weight very easily. What are the specific things that we will ask them to eat or do to be good in there and stay motivated to reduce their weight?
Ma'am, general low carbohydrate diet, ma'am. So I just don't say low carbohydrate diet, but I usually ask them their routine. I ask them what they do. They wake up, when do they wake up, and till they go to bed, what is their routine? And I try to modify it for them. Say, because again, as I said, it is different for each patient. We may have a patient who takes only 2 idlis and she may still be obese, and there may be somebody who takes 5 idlis, they're still normal weight. So I try to modify according to that particular patient. I don't recommend any particular fat diet as such, and I don't recommend completely omitting any like form of nutrient, like complete elimination of carbohydrates, I do not say. But I tell them to, explain to them in such a way that their daily carbohydrate intake is cut down at least by 75% of what they've been taking, ma'am. And a definite, like I keep telling them about physical activity. It's not just walking or brisk walking, especially in this lean PCOS. We see that their muscle mass is very less. So I've seen a lot of patients who've started doing these strength training exercises. I tell them to do strength training exercises, improve their muscle mass, increase their protein intake. And I've seen patients, like they will maintain the same weight, but then their cycles will become irregular. That is because their fat goes down and their muscle comes up. So the weight change may not be appreciated much, but their cycles come back to, their regular cycles. So I do see this, especially in all these college going kids and school going kids whom I treat for PCOS.
Ma'am, what's your take on weight reduction, ma'am? Do you really give them time? Do you really wait? Aruna, ma'am.
Yeah, for me, we ask them. It is very difficult. I have seen some patients sent before that they don't even come back, and they come back with a weight gain also sometimes. So
They
what we
come
have
back.
done is, yeah, that's the. So we have assigned a particular nurse to these patients, given and they follow them up on a weekly basis, update us on weight reduction, and we have a dietitian who follows them and gives them a star that when they reduce the weight. All this motivates them. So maybe a group of 10 people who can be put in a group and then stay motivated, and they put the messages in their group about what they eat every day. Maybe the other person also will take it up. So this is how we are motivating. Enrolling them into diet programs and gym, all that we are not motivating much. But a regular lifestyle, as she told, and our dietitian and our nurses do a wonderful work. Whenever I tell them that their BMI is more and you have to take care of them, they'll make sure that 3 months they'll reduce at least 10% of their body weight and bring back. But there are, as Bharati doctor has told also, there are some patients who tell me right on face when I tell them about weight reduction that enough, doctor, if you want to treat me, please treat me now. I'll not reduce my weight. They tell that like because of depression. But I think we have to put them on a psychological counseling. And last but not the least, the psychologists play a very important role because they're already depressed with infertility and obesity. So they need to be motivated. So once the motivation is there, it is going to be a fantastic work because the office work, their psychological depression, and the obesity complexity is too huge. And I think PCOD should not be stopped with the childbirth. I had 2 or 3 patients whom we have delivered, and after 7 to 8 years, they again became very obese, and I had to do a hysterectomy because they developed C endometrium. So I feel personally to take up PCOD into our everyday system of every other doctor that once you have a PCOD patient, it's like a diabetic patient who is there with a diabetologist, that we have to take care of the patient and advise her even after childbirth that they have to have a regular menses and they have to monitor and make sure her weight gain is not very high, and they have to be coming to the doctor once the menses is not happening at least 6 times a year. So all these are lifetime lifestyle and lifetime changes that we have to tell to the patients. As a fertility specialist, we stop with the fertility and delivery process, but they are struggling even with cancer and all the diabetes, hypertension, lifelong issues. So it is a metabolic disorder. So lifestyle and lifelong modification is needed. That's what we tell to the patient, that be alert, and even after delivery, don't be very lethargic and don't gain the weight back, because they are motivated till the conception. But after the conception is over, they rebound, weight gain is too high, and they get caught in this vicious cycle of metabolic syndrome. Thank you, doctors. I think the audience are also very happy. Any questions more? I think it is good. Both of you did a wonderful work. I'm very happy that you did the session very well. We will be every second Friday, we are planning this webinar. So we will be sending you across this discussions. Listeners can also send the topic that they want to hear from us every month. So we will also be happy. So we have taken 2 fertility specialists every month and one topic where they discuss on the case scenarios and give their inputs. Thank you, doctors. Dr. Meena, are you here to give the concluding remark? I think Meena is out of station and still.
Yes. No,
Yes,
I'm
you're
there.
there. Okay.
Arina.
Yeah.
It was
Yeah.
an excellent session. Dr. Puvitra and Dr. Bharati have done justice to the topic. The case scenarios of PCOS and infertility were well discussed, and it was a excellent presentation by both, and really enjoyed the session
Thank
and was on time as well.
Thank you.
Thank you.
First
Thank
of
you,
its kind.
doctors. Thank you.
Thank you.
Thank you. Yeah.
Thank you. Thank you.